At Chelsea Hospital, Audrey Bergen is a physical therapist, and we're in one of the rooms where you're doing your craft. What does a physical therapist do?
Well, a physical therapist works with patients to try to help them recover function or help to relieve pain. So we're just here to help people move better and so that they can live their lives better.
And I understand that you also do neurophysical therapy.
Right.
What is that?
So neurophysical therapy is working to help people recover from a neurological disorder, such as a stroke or a brain injury. Anything that might affect their brain or kind of nervous system, their spinal cord. So it's a pretty big, broad area. And it's a little bit different than some of the common places where people go for therapy, where they go to orthopedic clinic, where they might go for maybe after they had a knee replacement or if they have back pain or shoulder pain. We can work on those things, but what we're really focusing on is helping people recover from that neurological problem.
Yeah, that's the image I have of physical therapy, having been through it myself on a couple of occasions. It's like a workout. It's a workout room, typically. With neurophysical therapy, what are the tools do you have? Is it a different set of tools?
Well, we still have a workout room. It's just that we do workouts a little bit differently. So a lot of our patients can't work out on their own, so we do one-on-one therapy with them their whole visit. And then I work a little bit more on things like balancing, walking. Maybe their limbs aren't working right after a stroke or having a tumor on their spinal cord. So we have to teach them how to use their limbs again, whether we can get return. We try for that, and if we don't, then we teach them how to get around without having full use.
How to deal with the results, the ramifications of a stroke or Bell's palsy or whatever the particular situation is.
Right, right.
People,
go ahead.
People are living longer, and people having memory issues. Are there things in neurophysical therapy that you can do that can help someone that might be having things that are affecting their memory?
Well, yeah, I mean, I do. If I know somebody has a memory problem, I might try to help figure out ways to help them remember, like giving them a piece of paper to look at. But we also have a team here. We have a team with occupational therapists, speech therapists, and a neuropsychologist. And the speech therapists and neuropsychologists really can help people figure out where their memory problems are coming from, and what part of memory. There's a lot to it. And they can help also. So if I see a patient for neuro PT, it's usually a team approach. So I might be working with someone who's also being seen by a speech therapist at the same time. And I can talk with the speech therapist about the best strategies to help educate my patients so that they can learn what I'm doing. And memory might be part of that.
So with the orthopedic physical therapy, you can see, it's a surgery in most cases. But with neurophysical therapy, it's the issues might not be visible. How do you diagnose someone that needs that therapy? Yeah,
we have certain tests that we use. So a lot of times somebody with a mild brain injury might be walking around and they might seem okay to other people. But when they come in, I can do certain tests like stand on one leg or how fast can you walk? And we have norms that we can compare them to other people who are healthy at the same age. And we can kind of determine where their problems are.
Can you do things such as someone who is aging might have issues driving? Are you able to do assessments of people for their safety?
Right. So as a physical therapist, I don't work too much with the driving, but we have occupational therapists here on staff who can do pre-driver screening. So what's involved with that is they have some pencil and paper tests that they do, and then they have a kind of machine that actually tests reaction times and some other things where they can check where if the person is seen having problems seeing in their visual field.
Mm. Are there things people can do to avoid coming here?
Oh boy. Well, I don't know. I mean, a lot of the times things that happen are just things that happen to people along the lifespan. So try to eat healthy and don't smoke, and drive safely, and wear your seat belts and wear your helmets when you're riding bicycles, things like that.
This brain fog from long-term COVID, is that something that could benefit from neurophysical therapy?
Yeah, brain fog is probably more of a cognitive problem, so I would probably refer them to the speech therapist or the neuropsychologist. But a lot of people who have COVID do have some physical problems. They've been sedentary and they need to get up and get some more exercise in, and we can take them slowly along the pathway. We have an inpatient rehab program here as well, and we have seen patients who have had COVID. A lot of them have trouble breathing, their heart rates are very high, so they do need a trained professional to help them exercise and get back on the road. And here is a perfect place for that, because if you go to an orthopedic clinic, a lot of times the patients are expected to just be exercising on their own, and here we really need to sit and work with them.
Besides some of the injuries that might bring someone here, what are some of the diseases that, such as Parkinson's, that give you patients you can work with?
Sure, yeah. With Parkinson's, we have a great program that we use. It's called LSVT, Big and Loud. And if a person qualifies to participate in that, it's a program where we help people to recalibrate their movements. So someone with Parkinson's tends to move very slowly, and over time their motions become smaller. And so this program has been proven to make changes within the brain where we can recalibrate their movements so that they start to get bigger again. And speech therapy has a similar program called Loud, where their voices can become loud again. So with the LSVT Big, occupational therapists and PTs, physical therapists, work together. So a patient would come in 4 days a week, twice a week for PT, twice a week for OT. And we work on these movements, but we also do it within a functional way. So we teach people with Parkinson's how to put their clothes on better, or how to get in and out of their car. I will go out to the parking lot and go and watch a person get in and out of their car, and we teach them ways to get in and out better. It's very, very successful, and people feel very good when they're done with the program.
Having all of that here so that you can refer the same patient to various specialists all on the same campus, that's got to be a big plus.
Yes, it's fantastic. Yeah, and not only is our occupational therapy, speech therapy, neuropsychology team available to work with the patients, but being in the hospital, we do have social workers that we can access for resources in the community. And I also have lots of friends that are doctors and nurses that I can use for resources as well.
And you can teach people how not to fall.
Yes.
Wow, that's awesome. Sign me up.
Yeah. All right.
And having been here 28 years, you must love it. What are the things about Chelsea Hospital that bring you here every day?
Yeah, Chelsea Hospital is a very unique place. It's a small town community hospital in an idyllic, therapeutic, wooded setting. We are here for our local communities. So people who maybe don't want to drive all the way into the big cities of Ann Arbor or Jackson. And we have plenty of good parking. But more than that, I think it's the way we work with people here and the community of employees. It's a small enough hospital, we know each other, we care about our patients, and oftentimes I see my colleagues and myself, we go the extra mile to try to help people in their recovery.
Audrey, I recognize some of the equipment that you have here, but there's some I don't, like what you have with you. What is that?
Yes, these are goggles. It's an infrared camera, and I use it when I work with people who have inner ear disorders. It's called vestibular therapy. When I started out early in my career, a lot of my patients said they felt dizzy. And I didn't have a lot of experience with that, and I started to explore ways to help them. And I became certified in working with vestibular patients. Inner ear problems are pretty common. The most common one that we see is something called benign paroxysmal positional vertigo, where little crystals in the inner ear get dislodged, and when a person moves, they feel vertigo for a short time. It gets to be pretty much of a nuisance for them, and a lot of people get kind of scared. They also are at risk for falling because the inner ear is also a sensor for balance. So it's real important that people come in and we can identify where the problem is and do maneuvers to make them feel better.
If someone does have vertigo or they have other neurophysical issues, how do they end up getting to see you?
Yeah, absolutely. First, they have to check with their doctor, and their doctor will write a prescription or a referral. And then either the doctor sends a referral here through fax or computer, or the patient can call us.
Awesome.
Yeah.
Well, thanks for your time today.
Yeah, absolutely. Thanks for coming.
Audrey Bergen, physical therapist here at Chelsea Hospital.